He mangara ronga ki te whenua. He whakaroa pā ki ngā tangata katoa. Hangata e te atua hi ngā katakau hoa. Ki rota ki tēnā ki tēnā o matau. Whakatangia tō rangiwa tapu. He awihine he tō hutu ia matau. He oka hoki I ngā mahi mō tēnā wei. Amen. Honor and glory to God. Peace on earth, goodwill to all people. Lord, develop a new heart inside all of us. Instill in us your sacred spirit. Help us, guide us in all things we need to learn today. Amen.
Amen.
Okay, Catherine, I'll get you to go around the room asking people just to introduce themselves for me, please.
June.
Hi, Catherine. It's June Mills here from the Community Health Council.
Dave.
David Allen, Dunedin.
Paula.
Community Health Council and other things.
Christiane.
Good morning, Christiane Scott, Health and Disability Advocacy Service in Invercargill.
Tanya.
Kia ora, Tanya Mason, Regional Disability Advisor for the Ministry of Social Development.
Kim.
Hi, Kim from the Health and Disability Advocacy Service, Dunedin.
Lanita.
You're Lanita Russell. I'm the Chair of the Community Health Council.
Katie.
Kia ora, I'm Katie. I work for MS Otago.
And Marie. Marie, I don't know if you've got audio. No, it's okay. I think that's everyone, although everyone's moving on my screen. So if I've missed you, please speak up.
Okay, what we might do when people join the meeting later, we might just get them to do a quick introduction. Okay, so I'll just give you a little update on what we have been doing. We've had two meetings. We had one in May, one in July. In the May one, we had Andrew Size from the Well South. He's a public health medicine registrar, and he was talking about the proposal of Well South to develop a disability action plan. And he was saying how the role is to support primary health care to over 300,000 people in the southern region, with some direct services and work to improve population inequalities, excuse my language, which is really good because it sort of fits nicely with what the Te Whāroa Southern's Disability Working Group strategy is. We had a researcher from the University of Otago talk to the group in May, and looking at using data from GPs to lead into research projects, and was wanting to find out ways from the disability community what research projects they should be focusing on. I talked about some accessibility audits I'd undertaken, with the main one being the in Southland, the community centre. It was initiated because they're looking at replacing the roof, and if building work requires a consent, then it has to be supported by an accessibility audit. Interesting, the building used to be a residential care for the elderly, so it was a lot of things were very compliant. A lot of things which could be implemented to bring it up to a more universal standard. However, of course, universal standard at the moment is not law, and it's only the goodwill of the building owner. But the good thing is the Whāroa is trying to make sure that they do future-proof their property. We had positive feedback from the 30th of April quarterly forum, and disability training sessions have been rolled out, facilitated by Catherine, to the 4th floor of the Dunedin Public Hospital. We had feedback on the revised regional health and wellbeing plan that's been rolled out, which is a big document, about 68 pages long. And Catherine talked on a proposal that the Te Whāroa Southern become a sunflower supporter. The sunflower lanyard, for those who are not aware, is a lanyard that people with hidden disabilities excuse me, could wear. And that way, when they go to organisations that support the lanyard scheme, staff will be aware that that person may require additional support or assistance, or it just requires certain situations, certain quiet rooms or whatever. It doesn't guarantee that you'll get assistance. It just makes people aware that you may not be able to act on their requests. We did a roundtable in excuse me, in May, around the table who was present, and the main things that came out of it was Oamaru Waitaki have an issue with no shuttle to get them to hospitals. The St John's were talking about having, that would be about 2 years away before they could provide something. They were looking at a feasibility study. Also, there was concern that some toilet seats in some hospitals are too low. And that's interesting, excuse me, because the legal requirement for toilets in public facilities in New Zealand is 460 millimetres high. Australia, it can be between 460 and 480. So it's interesting, again, how this hasn't changed in over 20 years in New Zealand. So maybe when the building code gets changed, which is something the government is looking at, but it's not, it's in the background that they're going to be looking at it. So they may be looking at improving the standard. Yeah, Stronger Waitaki are looking at putting together Human Rights Commission, what marginalised communities exist locally, and find representatives to get together. So that's quite good. One of the representatives attended a Whakaha Pacifica strategy plan, which they felt was really like lip service and that was badly run, which was disappointing to hear. And someone had a meeting with New Zealand, the New Dunedin Hospital, and they were disappointed in the attitude of lead architects with consideration of disability. That was a little bit disappointing to hear. And that was sort of from our 17th of May meeting. With July, we started off going through the actions update, which we sort of do at every meeting. And 4 members have been appointed to the Well South Disability Action Plan Steering Group, so that's really good. Awareness Month recently completed the Disability Awareness Month was recently completed on the 4th floor, and there was 90 staff had been taking part. I just see that we've got someone else. Chris, do you just want to introduce yourself for me? Thanks.
Kia ora koutou, Chris Ford, Policy Advisor for Civil and Central at Disabled Persons Assembly.
Thank you, Chris. I don't think anyone slipped in without me seeing, have they, Catherine? Okay, so Catherine had done the disability awareness session with the 4th floor. 90 staff had been completed, which was mainly nurses, but also some healthcare assistants. The training was well received, and it's also been one undertaken with the charge nurse managers in Southland. We had Sandy Siganth, the team leader of the patient inquiries team, attended to talk about having a pay wave installed at the front desk at Dunedin Hospital. she outlined that for several years her team had been observing customers' experiences and challenges with trying to pay at the desk. The desk height, although compliant, where they had the EFTPOS machine was not really accessible. So watch this space. We've really endorsed it, and we're looking forward to seeing that implemented. We also talked about a yellow envelope, which is currently in place for consumers from the aged area, aged care, when they go to hospital. The envelope contains all the relevant information that they need at the hospital, and we're looking at ways whether that could be implemented right across the board to anyone with needs. I mentioned in May that we talked about endorsing the Sunflower scheme, the Hidden Disability Sunflower, and this is going well, and membership has been purchased, and we're looking now at rolling that out. So I don't know if you want to talk a little bit more on that, do you, Catherine?
I probably don't have too much to add to that at the moment, other than to say that we are putting in place a comms plan and a rollout plan for the education of that.
Awesome, thank you. Yeah, it's something that's really good. It started in the UK, mainly at the airports, and it's been really starting to grow internationally, and it is a great system. Supporters, if they wanted, there's various things. You can wear a lanyard, which is slightly different from the disabled person's lanyard. Just saying I'm a supporter. There's badges that the supporters can wear, T-shirts and things like that. Next time you're at the airports, look out for the sunflower, and it will say sunflower support, and then of course we'll have that in the hospital. There is potential concern about the staff wearing lanyards if the lanyards were to be borrowed or provided when people come into hospital. So they're sort of looking at ways that they could be cleaned. So the idea if someone turns up at the hospital instead of having to buy a lanyard. And it was interesting, I think someone from Awaitati said that CCS were charging, off the top of my head, $50 for a lanyard, where I think they're under $10 if you buy them personally, so someone appears to be making a little bit of money somewhere. I gave an update on the accessibility audits I undertake. When I do an accessibility audit, it looks at all disabilities, not just a wheelchair accessibility audit. As I mentioned, I make recommendations on the building code, and then best practice recommendations, which is to make something more up to date. We finished off with the round table, and there was concern raised that when seeing private practitioners, that the information is not getting passed on to GPs. So it's looking at ways that this can happen. We've got what's called the South Island, or it's called SouthPICS, which is a South Island information system that all of the patient information is on, and I understood that the system is talking to the GPs and the health centres. And yep, our meeting's finished there, so that's everything we've been doing. Bi-monthly, I give a little update to the Community Health Council, and that's really a shortened version of what I've just given you guys. Something that we also spoke about gave an update on the physio pool. I don't know if anyone's aware of where we're at with that. Excuse me, a feasibility study was undertaken by Feldspar Associates, and they were looking at various ideas. One was to bring the existing physio pool right back up to date, compliant regards all building code standards. Then they looked at moving to another site and have a like-for-like physio pool. Another standard was having what I say is physio pool on steroids. By that I mean having the physio pool but attached to it a gym, a cafe, or things like that, so that it becomes somewhere that people will go other than just going to the physio pool. There'll be a lot of other facilities provided. That would need a new site, and they were talking about possibly at the Kensington end of the Oval. I was there last night at the Kensington, just having a look, and yeah, it's quite a good site. However, you've got there what's now been known as the tent village, which is there's about half a dozen, if not more, tents being used by the homeless, which is quite sad. There's toilets set up there, etc. Further, going back to the physio pool, what they're also considering is approaching the Dunedin Council to see if there's a way that they can initially open the physio pool for the time that a new pool is being prepared. However, that would need over $1 million to bring it up to standard. And then there would also be close to $400,000 a year loss that would have to be factored into it as well. So I understand they're putting a proposal to work with the Dunedin City Council to see that we do have a hydrotherapy service. So really, that's watch this space. The trust is, this is the last thing it says, the trust is awaiting Health New Zealand to advise whether a lease for the existing physio pool site, including the plant room and car parking for at least 10 years, and preferably longer, would be available. And that 10 years is the figure that they believe it will take to actually extend, get a site, get a new facility built. So that is really an update of where things are, what I've done in the last quarter. Any questions, or more than happy to try and answer them. I should have talked a bit slower, Catherine.
That's okay. Okay.
There's something that I touched on, the patient information, and it's something that is sort of been ongoing, but we've been trialing it with some of the disability working group, that every time my file, for example, is opened at a hospital, it will come up with John Marrable, paraplegic, and sort of every page they open, there's going to be this banner across which will identify what needs I need. So not that I want to go down to the hospital, but I'd like to find an excuse to just see how it works. The last time I presented to the emergency department, the doctor who saw me had obviously just had training to deal with spinal cord injury patients of T6 and above. Someone who broke their back, T6 and above, can suffer from autonomic dysreflexia. That means that any injury I have below my spinal cord break, the messages don't go to my brain like they would for someone who is not a spinal cord injury patient. This can result in my body going into shock, high blood pressure, and things like that. And this doctor was very concerned, which was really nice. He said, now, because of your spinal cord injury, your T5, I realise I have to monitor your blood pressure. And I said, yes, you're correct. However, that's only if I've got an injury below my break. My shoulder is what I've been admitted for. That's above my break, so you don't have to worry about my blood pressure. And he looked at me as if I didn't know what I was talking about, and he kept coming back every half an hour to check my blood pressure. And on the third visit, he said, oh, look, I'm glad I'm doing it. Your blood pressure is up. And I said, I think that's because you're not listening to me. The autonomic dysreflexia will not be an issue in this case. So in some ways, it was good that he was concerned, but then it goes back to something we've been addressing right from day one, is we know our bodies, please listen to us.
Yeah.
So it's interesting. I ended up not getting my shoulder looked at, and I got discharged with a morphine injection in my shoulder. And it turned out I'd torn the ligaments and things like that. So, but the good thing was my blood pressure was okay. Anyway, I waffle. So if anyone wants to, please contact Catherine and discuss about what you'd like have put on this on your file just as a little banner that comes up every time your file. And the good thing is, as I said, that banner remains there. So when they flick through other pages, that banner's at the top, I understand. Catherine's giving me a nod, so that's good. Catherine, do you want to take over and talk? We've just had David King join us. We'll wait until he comes live.
Just while
David,
he's connecting to audio, I've had a message from Katie who's having trouble with her mic, and she just wanted to add for everyone else that in terms of the travel issues from Oamaru to Dunedin Hospital, there's someone who runs a private business who's offering transport to Dunedin Hospital.
And further to that, David King, I'll just get you to introduce yourself, and then I'll go back to.
All right, David King. I'm with People First New Zealand, a self-agency group, same with TPI self-agency group. I with your way on the national committee in Dunedin and the national one. Your way, the national group in Dunedin and the big one, national group across New Zealand and disappointation.
Excellent,
and
thank you,
of the Sea Council Advisory Board with John. I see. Yeah.
Excellent, thank you, David. So yeah, I mentioned that one of our working group meetings that the St John's were going to be doing a feasibility study and think it's going to take 2 years for them to provide a shuttle from Waitati. The last meeting, it was updated that they've been given the word that 2 years is unacceptable. We need it sooner than later. Interesting, some of the consumers in the Waitaki area are even going to Timaru, which is quicker. Interesting, some people are saying that when they're out of town, they really would like their appointments later in the day. And then there's other people who are saying that if they're coming out of town, they'd actually want it earlier. So it seems that, again, that when people are being offered appointments, the person should actually be given the opportunity, not just make the assumption that you're out of town, we're going to give you one later. So again, it's something that we don't all want the same level of service. We want the level of service that we want.
You dynamite what everyone needs in different times.
Exactly. Yeah. Catherine.
Thanks, John. Look, this might be a good opportunity, especially because John's mentioned that in his updates to run you all through the training that has been rolled out on the 4th floor and which will be rolled out in other areas of the hospital eventually as well. So just bear with me while I try and share this with you. Hopefully now I can't see anyone now. Can you see my screen?
Yeah, we've actually got the split screen where you've got the main, for example, slide 1 on one side, slide 2 on the other.
Oh, okay. This might be testing my technological capabilities.
While you're doing that, Marie, did you introduce yourself before, sorry? That looks good, Catherine.
Is that better?
John, I miss anything out for meeting?
Yeah, I'll fill you in on that, David. I was just giving an update. Really over the keynotes that we've done. David helps me produce the Disability Working Group notes, the keynotes into EasyRead.
Yeah, I'm still waiting for the payment to come through on the last one. So waiting for it. Yeah.
We can talk about that, David. Yeah, so I think, did Marie join us before, Marie Brosnahan? Marie, do you just want to introduce yourself? Thank you.
Murray was having microphone problems before.
Okay,
I'm
no,
not sure
no
if-
problem.
Yeah. Okay. Are you okay for me to talk? I can't see anything
Yeah,
apart from my own screen
yeah.
at the moment. Sorry.
No,
Okay, great.
you go ahead. You've got page 1 up.
Okay, great. All right, so this is the training that has been developed in conjunction with consumers and with clinical leads over a period of several months, and has been rolled out on the 4th floor, which is a surgical ward in Dunedin Hospital, and also with the charge nurse managers in Southland so far. So the learning outcomes of this that we want them to understand the rights of disabled people, how to understand their wishes, what good practice looks like, how to ask the patient about themselves and their disability and how best to support them, how to be flexible in their approach, not to be scared of disability, especially if it's something they're inexperienced with, and best practice to ensure that there's no barriers to receiving care. So I'm really clear at this point with the staff that they won't get all of the answers to everything in this session, but that I'm trying to sort of give them some ideas about how to find the answers themselves. So we start with a series of patient quotes. There's about 12 of them, and they're little laminated cards. And I go around the room and just get them to stand up and read that quote aloud. Some of them are quite profound, actually, and they all relate to the experiences of consumers in our hospitals. And the idea is to centre them into feeling the way that consumers feel, and as we go through the rest of the training. I'll give you a couple of examples of those. One is that someone was told, I just needed more self-discipline. Someone else, a quote was, I don't want my children suffering because of my communication barrier. I don't want to suffer because of my barrier, and I don't want to see anybody else in my position suffer because of a communication barrier. Someone else said, we don't want to raise any fuss. We're seen as difficult people. Someone else said, in relation to a family member who was in hospital, they said, we are exhausted and we need to not be feeling like he doesn't matter. I'm talking about their family member. So the idea is to have our staff understanding how people feel in those situations. And they're usually fairly somber by the end of this section. So then I briefly recapped the New Zealand disability strategies just to say there is an overarching piece of work, and these are the types of things that people should be able to say when they are experiencing healthcare. And just a couple of those. One is that I feel valued and important in the community. Health services for disabled people are good and easy to get and to use. So I'm quite clear that this is the gold standard, and that we know that we're not there yet, but that this is what we're trying to achieve. So then we talk about models of disability. And the first model being the medical model, and that disability lies with the individual, and that they must adapt to society. It's very clinical, and with the idea being there's something wrong and that we'll try and fix it, or that you should try and fix it. And then we talk about the social model, and how that talks about what makes someone disabled is not the person, but the attitudes and the structures of society, and the fact that we're not fully accessible. So they are disabled by the world around them rather than something inherent in yourself. And I also talk a little bit here about terminology. So the use of the differently abled is one example. I also use a couple of examples from people on this call, actually. One is one that John gave me, where the CRIP example, John, where, it's okay for you to use that with someone else in a wheelchair, but not okay for any of us to use it. And I also use the example of Paula and Dave when I was at your place one time, and you talked to me, you called me a sightling. I think I've told you this, Paula. And how that was okay for you guys, but it's not okay for me to use it. And I'll just try and give a couple of other examples as well to show some of the terms that people might hear when they're in hospitals, and the way how they should interpret those terms. And I also talk about how people, often the trend is that people prefer to be a disabled person, as in disabled by the world around them, but that some people still do prefer to be a person with a disability because that's putting the person first, and that it can be challenging to know what the right terminology is to use, but that trying to get it right is important. And also say here that it's important not to be scared of disability because it exists, whether they understand it or not. But if our staff understand it, then they're more likely to be able to create a better experience for everyone involved. And then briefly talk about the human rights model and that it's a natural part, disability is a natural part of human diversity. And then I have this quite cool cartoon that John gave me actually. And it's a person at the bottom of a flight of stairs in a wheelchair, and there's a sign that says "Way in, everyone welcome," and then a couple of speech bubbles on either side. The medical model says her impairment is the problem, they should cure her or give her prosthetics, and then the social model says the stairs are the problem, they should build a ramp. And it just shows how there's two different ways of looking at that one situation. So this slide is quite a meaty slide actually. And it is full of a lot of information that I've had, again, from several people on this call and from within the working group, and also other consumers that we've had other feedback from as well. And it's basically about how disabled people have said that they want to be communicated with. So, excuse me, asking before you help. So just because someone has a disability, don't assume that they need help. Orientating blind consumers to the environment, letting them know where things are, what you're going to do, who is in the room every time you come in, who you are, what you're there for, anyone else that's there with you as well. If you need to touch a person or provide any medication, etc., then making sure that they're fully aware of everything that's going to happen before it happens, and what it's going to feel like. So you can't just say, oh, I'm going to check your blood pressure now. You need to sort of talk through everything that's going to happen. And I also talk about the meals as well, even though the audiences so far haven't been the people that would bring the meals, but just making sure that they're aware that just because a meal hasn't been eaten, it doesn't mean they're not hungry. They may not have been aware that it was there. New Zealand Sign Language interpreters, so just talking through, and I always check at this point to make sure that everyone actually knows how to book an interpreter. The good news is that most people know about how to book an interpreter within the hospital using our interpreter coordinators and our duty managers for after hours. Often they're not aware of the relay service, so that's a good chance for me to highlight the relay service as well. Just recognising that consumers with disabilities might have other support needs and might rely on whānau members to be their voice if they can't express themselves fully, and that we need to respect this. Also talk here about making sure that we are still talking to the consumer, that we're not just talking to everyone else around them and forgetting that that person's there in front of us, that we are engaging them fully in the conversation. Recognising that the consumer is a whole person, not just the disability, not just the medical condition, and all facets interrelated. I actually got a really good example of this recently from another conversation with another consumer advisor actually, and they told me how a person they knew had come into hospital for surgery, and this person wore hearing aids and was sort of struggled to hear some of what was being said by some of our healthcare staff. But what they said they came away feeling was that they were just a bit, they were one bit, and that was the bit that was being surgically repaired, and that there was no other bits to them. So the fact that they had a hearing impairment and that they had some mobility issues, I think, as well, none of that was sort of considered. They were just one bit, and that was the only bit that we were interested in. And I just thought the use of that word was quite strong, and something that a lot of our teams could probably relate to. We also talk about using all the tools that we have to highlight consumers' communication needs and making sure that everyone knows about these before the interaction. So we have on our inpatient wards, we have a My Care Plan board, which sits behind, and I know we've spoken about these on these meetings before, but just highlighting the importance of making sure that that's completed and then also checking it when you're going into a room. Now, the good news is that when I did this on the 4th floor, they were also doing some really heavily auditing on their My Care Plan boards, and they've had some really great success with making sure that those are completed and they are being used. So that's been one really positive outcome. Also talk about things like the CIPEX program, the patient management system that John mentioned earlier, making sure that if we find out information that we need to include it there, that it needs to be on the physical file. We have a patient admission form now that also asks whether someone has a disability and what accommodations we might need to make. So checking that, and that's also being conveyed to other people that are involved in the care as well. And the final point is just actually to ask them. And I've got a couple of examples of how that can happen. How can we best communicate with you or your family member in regards to mental health? Is this your normal experience of this symptom? What else do we need to know to look after you or to look after your family member? And using that invitation. And all of these examples are ones that were given to me by consumers when I was developing this. So they are things that have been evidenced, I suppose, to be effective invitations for our staff to get that information. Also cover the Hidden Disabilities Sunflower Lanyard, which again John mentioned earlier. So it is that green lanyard with the yellow sunflowers on it, and it is something that can be worn by a person with an invisible disability, and it signals that they just might need a bit of extra support. And as John mentioned, we will be having that later in 2024. So then just to cover the 3 main themes that we get from consumer feedback, particularly from consumers with disabilities, treating the person as a whole person, excuse me, communication of consumer needs to the entire healthcare team, and physical and communication needs of consumers with a range of disabilities. So then I swap that over to the teams. So we break them into 3 groups, and there are 3 case studies, which so far have been mainly surgical, but I have also developed some outpatient case studies for another outpatient group that I did this with. And so the idea is that they have a case study about a patient who might come into their ward, and there's a few questions about how they might get the information about that person, what they might need to think about as they're caring for that person, how they might ensure that everyone else in that healthcare team knows how to communicate and how to look after this particular person. There's also a couple of questions around discharge as well, and what other things they might need to think about in preparation for discharge. So then we come back together as a whole group. I'll stop sharing actually, because then I can there we go. I'll stop sharing because then I can see you all. Then we come back as a whole group, and I get them to talk through those case studies and get input from other people around in the other groups as well. And so the whole session usually lasts around 40 to 45 minutes, and it's been quite effective so far. We've had some really good engagement, which has been really positive, and I will be rolling it out on the 3rd floor some point this year, probably a bit later in the year, but we will be eventually getting it across to lots of other areas as well. Happy to take any, that's a very quick run through, but happy to take any questions.
I've got a question. Am I off mute?
Yep, you're off mute.
2 questions. So what's on the 3rd floor?
Surgical as well. Is our other surgical floor, sorry.
And do you know, you talked about interpreters for deaf people, but what about interpreters for like refugees, I saw a thing that implied that, because that used to be through Te Whatuora Southern to book interpreters, and I think I read a thing that said it's now gone to the DCC. Is that right? Do you know?
We definitely still have interpreters contracted through Te Whatuora Southern. I only talk about the New Zealand Sign Language ones in this module just because we focused on disability, but we definitely still have our interpreters available as well.
Oh, okay. Well, that's good. Thank you.
Yep, no worries.
Sorry, guys, my laptop decided to crash on me halfway through Catherine's talk. So sorry about that, Catherine.
It's okay. I hadn't even noticed. I couldn't see anything apart from my own screen.
Interesting. I think it's someone who's on the spectrum. They can have an issue with giving a pain scale. The normal thing that the medical profession seems to do is you're in pain. What's the level of pain? 1 being okay, 10 being the worst. I've been advised that people on the spectrum sometimes cannot, answer that question that easy. Have you heard that, Catherine, or anyone else on the group? Yeah, what I understand, they have to sort of just explain, like, the pain could be like if you had burnt yourself or whether you're holding ice or something. They have to be able to compare because what is normal description for us may not be a normal description for someone on the spectrum.
I haven't had that feedback, so I'm really interested in how I might incorporate that. Maybe we can talk about that offline and I can incorporate that as well. Yeah, thank you.
Yeah, that's very interesting. I mean, we've all got a level of pain, and we also always know what side. Lynette.
I had quite a bit of experience with that because of working alongside people with dementia. So very, very similar issues. And pain scale is generally faces and ranging from the frown to the happy face. And that is well researched as being the best tool for using for people with dementia, and I would think probably with any other neurodiversity, intellectual disabilities as well. It's well researched as being a tool that actually works. So it's something that we should probably have as a backup in all of the wards, really.
Yeah, that's what I'm thinking as well. I didn't know about this, and this is great.
I can provide you with a wee copy of it actually, because they used to give out wee cards and they had these happy faces on them, but I can send you the information, Catherine.
That would be really good. Thank you.
Yeah.
It may be something that they're using and I just don't know about it, but it would be really good to know. Thank you.
Thanks, Lynette. I was actually talking to someone when I was in Japan. Their father has got dementia, and I mentioned about the smiley face because that is also what this person on the spectrum told me that they use. That, yeah. But it's funny, it's been around for quite a few years, but I think it's something that keeps going around in the cycle, but the cycle sometimes may be a big, long circle. Yeah. I think it's important that the medical staff, whether they be the person, the concierge, or right through to the person doing the cutting open or whatever the procedure may be, is aware of these things. Yeah, or not necessarily they don't need to be 100% familiar with it, but know where they can get the information, or they know they've got someone with dementia coming in. Let's access a smiley card or whatever. So and that's something that I didn't touch on, is the Living Well Disability Working Group has been working with the Te Whatuora to update a list of all the health and disability providers and organisations in the southern area. And that's well on its way to being finished. There was a few, like anything, the draft, Catherine went through the draft one and identified areas that needed to be addressed, which I believe has been addressed or nearly completed.
Yeah.
And the idea is that the doctor doesn't need to know all the information, but can know that this directory is there and either source the information himself or provide it to the patient or the patient's family. And also, while I'm talking about information, there was talk about in the new hospital build, and I will make inquiries, that instead of having pamphlets around, because you've got the infection risk and things like that with having pamphlets around, they were talking about having QR codes. So, for example, you might have the brain injury symbol, then the QR code, so that if someone needed to, they could just scan the QR code and have all the information. And there was talk that if the person didn't have access to the print from the QR code, that someone, the concierge at the new hospital, would do that for them. It's something that was being looked at, that we might follow up on that, Catherine, for our next DWG meeting. No, thanks for that update, Catherine. Any questions, guys? No questions so far. So feedback, Catherine, from the last.
Yep. I will attempt to share again. Can I just check, when I shared the last time, could everybody still see Bridie on the screen? Oh.
No.
I thought I'd set it up so that, one moment.
I think it was as it should be, Catherine. We couldn't see your notes or anything like that. We could just see the main screen, and I think that's what you wanted, wasn't it?
Yeah, it was, but I still wanted everyone to be able to see Bridie as the interpreter.
Yes, I can see Bridie.
Yeah,
but
she's the main one on the screen.
But could you see Bridie when I was sharing my screen? No, yeah, okay. One moment, I'll try and be clever with.
Bridie didn't introduce herself. I didn't know we had her on the thing.
Sorry about that, Paul.
I
will punish myself for that.
Yeah, I know that the interpreter is sort of only there as being there to provide information for those that need it, but I think I have raised it before that we should know who's in the room.
Yeah, my apologies for that.
It's all good.
Catherine's just trying to work out to get Bridie pinned so that she doesn't disappear.
Okay, I might have done it.
You've done something.
Okay. Right, can you see that? And can you see Bridie?
No. Bridie, no.
Okay. What I'll do, I'll just keep Bridie there and I will just talk through the presentation. So just to recap, at every quarterly forum, we just briefly talk about the feedback that we've received over the last quarter through our feedback channels that relates to disability. One of the reasons that we do this is because we are aiming for partnership in our consumer engagement, which means that we are not only collecting feedback and metrics, but that we are also in metrics on those feedbacks, but that we are also reporting those back to our stakeholders, which includes our community. So I've got 4 items that we received over the last quarter. One was the complaint from the mother of an autistic child who became quite distressed while they were in our emergency department. The mum was providing advice about how we could change our communication style to accommodate that child's needs, but we weren't really hearing that and taking that on board. So the child became quite distressed and wasn't able to control their emotions, and it became quite a traumatic event for everyone involved, really. So we apologised, and the staff member involved was spoken with. And it just, as we've already mentioned, we will be rolling out the Hidden Disability Sunflower this year. So we will be contacting that whānau and offering a lanyard to them as well, which will hopefully signal in the future if they come into our emergency department that they may need that extra little bit of support. We also had a complaint about the need to consider post-operative care. So this was from a consumer who had had surgery previously, which had practical challenges for them post-operatively related to their disability. We did need to consider further surgery for that person, and the consumer and their support person were very clear about the post-operative conditions which needed to be met to ensure that not just the experience in hospital, but the experience after their discharge was safe and comfortable for them. So the service and the consumer and their support person are now working with Your Way Kia Roha in conjunction to develop a plan so that that surgery can be carried out and the discharge safely. We had a complaint about a lost hearing aid. There were some communication challenges about whether we would be replacing that, which ended up being quite delayed. The patient actually passed away prior to this being progressed, which I think was distressing for their family, as they didn't have as much hearing capacity in their last few months. The charge nurse is going to continue to look into how we address this for future situations, though, so that the experience is still being utilised by us for some positive use. And we also had a complaint about the delay in surgery for grommets. So this was a child who had been waiting quite a few months for grommet surgery. There was concern that their hearing and speech were declining and the child was due to start school shortly. That's currently being investigated, so I don't have an outcome for that one. But just a reminder about our contact information. So if you have anything that you'd like to raise in relation to disability, then, and I'll put this in the chat in a moment, the email is disability@southerndhb.govt.nz. And if you have feedback, compliments, suggestions or complaints, can be sent to our feedback@southerndhb.govt.nz email address at any time as well. I'm happy to take questions on those as well.
Thanks, Catherine.
How easy is the complaint procedure? People to find and work out.
What was that? I'm sorry.
Sometimes complaint sheets are not very easy to find, or don't, and the house is not easy to work with, not just clear how to do it.
Who's not clear? Sorry, I'm having trouble hearing you. I'm sorry, Dave.
Complaint, like, how easy is the complaint procedure to understand and know about it?
The complaints.
Yeah, how easy to find is, how easy to.
Yeah. So we have several ways of making a complaint. So there is an email address. We also have a web form on our website, or there's also a phone number which you can phone up and speak to our feedback team, and they can record that, talk through, make sure that it accurately reflects what you want to say, and then submit that on your behalf.
How unknown really is this all to patients with learning disability, this all. Yeah. How unknown this is.
Yeah.
Interesting. I think we were looking at trying to change it from a complaints form to feedback, but there was an issue, wasn't there, Catherine, that they wanted the term complaints on the feedback form. Because to me, complaint is feedback. To me, feedback can be good or bad. And bad feedback is actually good because it means that the service can be improved. But somewhere in the national area, they said no, they wanted to keep it called complaints.
We definitely call it feedback. So feedback incorporates complaints, compliments, and suggestions.
Yeah, no, that's good. Yeah. No, thanks for that. I must admit the feedback does work because just after COVID and we were allowed to enter the hospital, there were issues with the queues to get in and things like that, and I provided some feedback which was actioned on. So when possible, the feedback is actioned pretty quickly.
It's great to hear.
Thank you, guys. If there's no more questions or concerns or whatever, we'll wind the meeting up. thank you all for your attendance. Thank you again, Bridie. Always good to see you. I'll finish with a karakia. Kia tau kia a tatou ke toa. Te atawai o toa te toa a wiki e tue karatiti. Me te aroha o te atua. Me te whiwhi kata ingatanga ki tā wairua tapu aki amene. May the grace of the Lord Jesus Christ and the love of God and the fellowship of the Holy Spirit be with you all forever and ever. Amen.
Amen.
Thank you all guys
Thank you.
for attending. Once again, Catherine, thank you for organising this. All have
Thanks,
a great,
everybody.
Thank you.
Have a good weekend.
you too.
You too.
Keep well. Thanks a lot.
Thanks.
Ka kite, thank you.